Now we're going to take a look at the layer of the dermis, which again is the lower layer of the skin. It's this whole area in here, or it's the middle layer of the integument, the whole thing. The dermis has a few different characteristics. One, well, I just said it's the deepest layer of the skin, but also is composed of connective tissue containing collagen and elastic fibers. These are arranged in a dense, irregular connective tissue. They're dense and irregular in this reticular region. So the dermis really has two different regions to it. We have a papillary region, which is this lighter color, this white stuff, at the top of the dermis, and it makes these little nipples or papilla. That's what it looks like. And then the reticular region is going to be all this darker middle region here. This has the meat, the bulk of the dermis is this reticular region. We'll take a look at each of these layers. But note also that in the dermis, we're going to have other things in there. We're going to have fixed fibroblasts. Fibroblasts are the cells, remember, that make our fibers, our collagen and elastin. We're going to have free or wandering macrophages. Those macrophages are the white blood cells that are going to phagocytose and get rid of bacteria. We've got mast cells involved with inflammation and several different types of white blood cells that we'll get into a little bit more detail later. So in this papillary region, this upper part of the dermis here, this is the most superficial part of it. It's made of areolar CT. So remember, that's that thin packing like material in there. It's got thin layers of collagen and very fine elastic fibers in this region. This is where we have the dermal papilla, which are the little finger-like projections going up into the epidermis, or you can think of the epidermis as coming down into the areolar or the papillary layer. And it's really important that it have this because, remember, epidermis here is made up of epithelial tissue. And epithelial tissue, you'll notice in this picture, has no blood supply in it. So all the blood is going to be in the dermis. So in order for the epidermis to get nutrients and to get rid of its toxic metabolites, it's got to send those substances down into the dermis. That's why these cells in the epidermis start to die off, because they're not getting good blood supply. So in these dermal papilla, you're going to see little capillary loops right here. So these are capillaries going from arterioles lower here in the dermis up in this papillary region. We see the capillaries, and that's where all the exchange of information is going to be. There's also going to be little Meissner corpuscles, which are nerve endings that are encapsulated, and we're going to see that for touch. And then we're also going to see free nerve endings, and you'll learn the difference between free and encapsulated nerve endings when we talk about the nerve chapters. But basically, this is where we're going to be sensing things like warmth and coolness with temperature, pain, tickling, light touch, and itching. All of that is going to be in this papillary region from all these different types of nerve endings. And the nerve, you can see, comes up into the epithelium just a little bit here. Not very far where everything is dead, but we have a little bit of nerve, but no blood supply up there. So then the reticular region is everything below the papillary region. In this region, we're going to get more dense, irregular CT. So those collagen fibers and elastic fibers are going to thicken up and get scattered more, but they're also going to be arranged in kind of this net-like fibers according to the different tensile forces. So where there's more tension, you're going to see more of these fibers lined up in a parallel fashion there. Here in this reticular layer, you're going to see everything that needs to get to the papillary region, because it comes from internally going through. So you're going to see all the blood vessels now, not just the capillaries, but the arterioles and venules. You're going to see this hair follicle, which is a little bit more substantial here in the beginning of the bulb of the hair. You're going to see different glands. So we're going to see sebaceous glands, which are going to be going to that hair follicle. You're going to see sweat glands, both sebaceous and sudiferous glands. Or the sebaceous gland is going to the hair. This one is a sudiferous gland, apocrine and merocrine glands. You're going to see going and extending up into the epidermis to go out. So this is a duct going out of the body. This is all, the dermis here is all attached to the subcutaneous region, which is the hypodermis, which is different. So this is all that fatty layer down here. So that's the dermis. I mentioned tension, and we call those lines of cleavage or tension lines. And this is, you can see now how these fibers would be lining up in that dermal layer. And what's interesting about that is when surgeons do surgery on people and they have to make an incision, they basically want to cut along those cleavage or tension lines because the skin will heal better. So if you know how those lines work and how the tension works, you'll be able to get your patients to heal a little bit more quickly. We can also look at different lines. These are epidermal ridges, otherwise known as your fingerprints. You've got those, they're little grooves of the epidermis that goes down into the dermis, or gets pulled down. And you see those in your fingers, palms, soles, and toes. They're made during about the 3rd month of fetal development. Like I said, it's the epidermis projecting down into the dermis. You still have epidermis in between all of these ridges. It's just getting pulled down that way. In that epidermis, we still have these sweat glands producing oil. And it's that oil that's actually the residue that's left behind that's making your fingerprints. These lines are genetically determined, and they never change throughout your lifetime. But what's interesting is that identical twins have different fingerprints. So there's something about epigenetics, and epigenetics kind of looks at how the environment manipulates your gene expression. So sometime in that 3rd month, those 2 little twins in the uterus there, even though they're identical, they're having different, something is different is changing how these epidermal ridges are getting formed. The reason that we have these, the purpose of these epidermal ridges are, one, primarily to increase your surface area. And by increasing the surface area in these regions, you're going to be able to have more friction and get more grip strength. You'll have greater tactile sensitivity, because remember, we have those free nerve endings and that those capsules that are coming up into this epidermis so that you can touch and feel better. And we'll also have increased blood supply to the stratum basale because we're increasing all of that surface area. So we're making more ridges, more places for that the papillae to come up into the epidermis there. We can also have stronger bonds between the epidermis and the dermis because, again, we have more of those ridges that are kind of interlacing and interlocking into each other more. So a lot of good reasons for having these epidermal ridges, which, again, make our fingerprints. Okay, so now I want to talk a little bit about skin color. Color is due to a pigment in the skin, and basically there's 3 main types of pigments that we're going to be considering. There's melanin, which can actually be a pretty broad range of pigments. Those pigments can be kind of a yellow-orangish to reddish to a dark brown to black. So there may be our deep dark colors. We'll have carotene, which is more of an orange color, and hemoglobin, which produces a red pigment. We'll look just kind of quickly at melanin here first. Melanin, we said yellow to red or tan to black. So we'll see quite a variation in people. Dark-skinned individuals are going to have more melanin in their epidermis, and lighter-skinned individuals will have less melanin, and their skin will be more white, pink, or red. The red hue is going to be mostly due to that hemoglobin, which is going to take over for the lack of melanin. What's interesting, though, is that these individuals have the same amount of melanocytes, or the cells that produce melanin. What differs among them is the amount of melanin that's in those cells. So the number of melanocytes are the same, whether they're Caucasian or black, but it's the amount of melanin that's going to make it in those cells make the difference. Freckles are accumulations of melanin. So I said that they can be orange to red, so that's what makes the red freckles. So you can have two different types of freckles. You can have light freckles, which are inherited, like this little guy has got. And I think we call those ephelides. Or we can have dark freckles, which are Latinginese. These freckles can be random. They are not random, but they can be intermittent due to sunburn. So sometimes when people get sunburns, they'll get freckles that'll show up for a little while. It can also be, and that's basically an overexposure to UV light, because that UV comes from the sun. We've also got other kind of freckles that come with age. These are basically liver spots, or age spots, people call them. And again, that's just going to be an accumulation of melanin that we see as we get older. Another type of accumulation of melanin are moles or nevuses. These can be due to overgrowth of melanocytes. That's what a nevus is. Basically, this could be a precursor to cancer. They're not cancerous in that they are not metastasizing, but they're all contained in this one little spot here. But they're something that you would definitely want to get a dermatologist to look at, and that might need to be removed to prevent that from turning into a cancer later on. Okay, so we got a couple other conditions here. We've got albinism, or if you've heard of people being called an albino, basically what that is they are not able to produce any melanin in their skin. So that's a genetic condition. Obviously they're going to sunburn very easily, but you can see their hair has no color, their skin has no coloring to it, or it's just going to be that pale white. And I should mention this person, it's kind of a fascinating story. This person right here is really a lady, and she's had these two children. So these are her kids. So although it's genetically determined, it's a recessive trait in that she has both the recessive genes. She obviously had children with somebody who did not have albinism, or passed on the gene that did not do that, so that all of her kids could have regular skin, but they could be carriers of it. So their kids could possibly become albino. Vitiligo is basically patches of skin where we have complete loss of the melanocytes. So in this person here, she's a famous artist. You can see she has got patches of her skin where their skin is discolored. Often we'll see it like this. And in fact, there's thought and speculation that this is why Michael Jackson started wearing the glove to start off, because he started getting vitiligo, and that started spreading to different parts of his body. And I believe he had multiple plastic surgeries because of that. Now we can look at keratin, and keratin is that orange pigment. It's a precursor of vitamin A. It's stored in the stratum corneum, which is vitamin A is stored there, so that's that outer layer of our epidermis. It's also stored in the fatty areas of the dermis and subcute, so kind of all around. Again, it's that yellow to orange pigment. We find that in carrots here, and also in egg yolks. That's the coloring, that center coloring of the egg yolk. And basically, people can look a little bit orange if they eat a huge amount, it'd have to be, of carrots or egg yolks that could possibly cause that skin to change color a little bit. So it's a little bit of a nutritional issue. Then we've got a few different colors here. The first one is cyanosis, or cyanotic coloring. That's basically a blue. So anytime that you see the root here, cyan, that's referring to blue. And often that's going to be due to low oxygen levels. We'll see that in the nail beds, the skin, and different mucous membranes. We could have a yellow coloring. That yellow coloring we call jaundice. Often that's due to a pigment called bilirubin. Bilirubin is a yellow pigment. When it's in the skin, you'll actually see that bilirubin can contribute to the yellow in your urine. It's going to contribute to the green-brown in your stool, and a lot of different things. In the skin, though, we call it jaundice. So you'll see that in skin, you'll see it in the sclera, or the whites of your eyes. They can turn yellow. We'll often see this in premature infants who don't have the capacity from their liver to break up this bilirubin. So they stay yellow. And what we can do is basically put them under bilirubin lights, which take care of that for you. and they break down the bilirubin until that little baby can start to produce its own enzymes to do that. We also can see it um, in adults who have liver disease, and so often people who are alcoholics that are getting their cirrhotic livers, and their livers are starting to break down and die off, they can't process bilirubin as well. And so you can see in their eyes start to becoming yellow, and the skin can start to become a little bit more jaundice like that. So that's what jaundice is. Erythema is basically a redness coloring. Here, the redness is due to an engorgement or a dilation of the red blood of the blood vessels. So it's bringing more blood to that area. It can be in little patches like this. And this person's maybe having a histamine response to some type of allergy. It doesn't have to be just circular like this, but it can be large patches of skin. It could be due to sunburn, where you get all your skin on your back is red at once. And again, that's just basically because you're having increased blood supply to that area. And the last one here, pallor or pale, that's going to be just the opposite of erythema. That's going to be a lack of blood supply, and that can happen when an individual goes into shock, when the skin blood vessels clamp down and they're trying to send that blood somewhere else in the body. So they'll have less blood going to the skin, because remember, the skin contains about 8 to 10% of your blood supply. So if you redirect that, you're going to look a lot more pale. Also, patients that have anemia, which is a lack of hemoglobin or some of those red blood cells. And we can also see that this is going to have an effect on the lips, where they have a very thin stratum corneum. We'll finish this section with just a quick comment on tattoos and body piercing. Basically, tattoos, it's permanent coloration of the skin. What they do is they inject ink into the dermis. They can, lots of injections up to, like, I think it's 300 times per second. But that dermis, remember, is permanent. It's not shedding off like the epidermis. So that tattoo is going to stay there primarily for a lifetime. It can fade over time. UV light can start to make it fade. Lymphatic flushing or scabs, if you have injured that goes down into the dermis, that can remove part of that tattoo. Basically, they can be removed with lasers. And what the lasers do is they're set at a certain setting so that the ink in the dermis will absorb that laser light, and that laser light starts to break up that ink into small enough little blotches so that the macrophages and the immune system can destroy that ink that's in there and remove it over time. But unfortunately, that can leave some scarring and some issues. And so when you're getting a tattoo, really keep in mind that this is possibly for a lifetime, and just consider that. Also, same with body piercing. Again, piercing through that epidermis and dermis, possibly into the hypodermis a little bit. And again, the main thing that you need to watch out here for is for infections, because you're opening up holes into a place that's not used to getting that. And so bacteria can get in there, and especially after during the first few weeks and months, you got to keep that thing really clean so that those tissues can heal. And then there's going to be scar tissue around that afterwards, and if you're getting large holes in there, it's going to be hard for them to heal if you decide that you don't want that later. That wraps up this section. We will now continue with the hypodermis moving forward.